Welcome to OET Answers.
Occupational English Test. OET Answers Practice Test, Listening Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now, look at the notes for Extract 1. Extract 1, questions 1 to 12. You hear a GP talking to a patient called Susie Kin. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Good morning, Susie Kin. How can I help you today?
Morning, Doctor. I've been feeling really off lately and I'm a bit worried. I'm not sure if it's something serious, but I've been extremely tired and I've noticed a few weird things happening with my body.
I see. Let's take a closer look at what's been going on. How long have you been feeling this way?
It started about 3 months ago, I think. At first, I thought it was just stress from work. I'm a teacher, and it can be really draining sometimes. But it's been getting worse, not better. I'm tired all the time, and now even the simplest tasks leave me exhausted.
That sounds exhausting. Aside from the fatigue, have you noticed any other symptoms?
Yeah, there's a few things. I've been getting these bruises, and I can't explain them. I don't remember hitting myself, but they just keep appearing. They're dark too, and my gums bleed a bit when I brush my teeth, but I just thought it was my toothbrush being too hard or something.
Unexplained bruising and bleeding from the gums can sometimes point to underlying issues. Have you had any infections recently, maybe colds or more severe infections that you don't usually get?
Actually, yeah. I've had 2 colds in the past couple of months, and I don't usually get sick that often. The second one took forever to go away. I just felt run down the entire time.
Any fevers or night sweats?
Well, not fevers, but I've been waking up in the middle of the night drenched in sweat. I didn't really think it was anything serious, maybe just stress or bad dreams. But it's been happening more often, and now I wake up tired too.
And how's your appetite been? Have you noticed any changes in your eating habits or weight?
Actually, now that you mention it, I've lost some weight, but not intentionally. I'm eating less, and I just don't feel as hungry as I used to. It's weird, because I've always had a pretty good appetite.
That's quite a range of symptoms. How's your energy during the day? Are there times when you feel better or worse?
It's pretty much all the time now. At first I thought I was just tired because of work, but even on weekends or after a good night's sleep, I feel completely drained. Like walking up the stairs or even carrying a bag of groceries makes me feel winded.
That's definitely something we need to investigate further. Have you noticed anything unusual with your skin or complexion, maybe paleness or changes in skin texture?
Yeah, I've actually been getting comments from friends and colleagues about how pale I look. I just assumed it was because I'm not getting enough sun lately.
Right. And have you had any joint or bone pain, maybe aching in your limbs or back?
Now that you mention it, I've had this dull ache in my legs, especially in the mornings. It's not unbearable, but it's definitely there. I thought it was just from sitting too much at work.
Have you had any other medical conditions in the past, or anything in your family history that could be relevant?
No, nothing that stands out. My family's generally pretty healthy as far as I know. I haven't had any major illnesses either, just the usual colds and minor stuff.
Okay, Susie Kin, based on what you've described, the fatigue, unexplained bruising, night sweats, weight loss, and paleness, these symptoms could potentially point toward a blood disorder. One condition we'll need to consider is leukemia. Have you ever heard of it?
Leukemia? I've heard of it, but I thought that was a type of cancer. Could I really have something like that?
Leukemia is a type of blood cancer that affects the bone marrow, where blood cells are produced. It can cause many of the symptoms you're experiencing, like fatigue, bruising, and recurrent infections. Of course, we can't jump to conclusions, but your symptoms align with some of the warning signs, and it's important to rule it out or diagnose it early if that's the case.
Wow, I didn't think it could be something that serious. What would happen next if you think it's a possibility?
The first step would be to run some blood tests. We'll check your complete blood count (CBC) to see if there are any abnormalities in your white or red blood cells as well as your platelets. If anything unusual comes up, we may need to refer you to a specialist, such as a hematologist, for further tests like a bone marrow biopsy. But let's take it one step at a time.
I didn't realize blood tests could show all of that.
Yes, they're very effective in helping us understand what's happening inside your body. If there is something like leukemia, catching it early can make a big difference in treatment outcomes. But remember, there are other conditions that can cause similar symptoms, so this is just one possibility.
Okay, I understand. It's a lot to take in, but I'm glad we're looking into it. What do I need to do now?
Extract 2, questions 13 to 24. You hear a doctor talking to a patient called Mr. Davis. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Mr. Davis, please come in. How are you today?
Hi, doctor. I'm all right, but I've been noticing something worrying lately, and I thought I should get it checked out.
I'm glad you came in. What's been bothering you?
It's my legs. For the past few months, I've had this pain in my calves when I walk, especially if I'm walking uphill or for long distances. It starts off as a cramp, then gets worse, almost like my legs are burning. I have to stop walking for a bit, and after a few minutes, it goes away. But it's happening more often now, even with shorter walks, and I'm worried it might be something serious.
That's certainly something we should look into. The symptoms you're describing, pain in your legs when walking that improves with rest, could be a sign of peripheral artery disease, or PAD. It's a condition where the arteries that supply blood to your legs and feet become narrowed or blocked, usually due to a buildup of fatty deposits. When the muscles in your legs don't get enough blood flow, they can cramp up, especially when you're active.
Peripheral artery disease. That sounds a bit frightening. What causes it?
PAD is primarily caused by atherosclerosis, which is the buildup of plaque in the arteries. This plaque is made up of fat, cholesterol, and other substances, and over time it hardens and narrows the arteries. Risk factors include smoking, high blood pressure, high cholesterol, diabetes, and being overweight. It's similar to how heart disease develops, but PAD affects the arteries in your legs, not the heart.
Well, I do have high blood pressure, and I've been a smoker for years. I suppose those aren't helping, are they?
Unfortunately, no. Smoking is a significant risk factor for PAD because it damages the blood vessels and accelerates the buildup of plaque. High blood pressure and cholesterol levels can also contribute to the narrowing of your arteries. But the good news is that PAD is manageable, and by addressing the risk factors, we can prevent it from getting worse.
So, what do I need to do? Is there a treatment for it?
Yes, there are several steps we can take. The first and most important thing is to address the lifestyle factors that are contributing to the condition. Quitting smoking is at the top of that list. I know it's not easy, but stopping smoking can significantly improve blood flow and prevent further damage to your arteries. We'll also want to manage your blood pressure and cholesterol levels more aggressively. I can prescribe medication if necessary, and we'll discuss ways to adjust your diet to help lower your cholesterol.
I've tried quitting smoking before, but I've never managed to stick with it. Do you think it'll make a big difference?
It absolutely will. Smoking directly impacts the health of your blood vessels, so quitting can slow the progression of PAD and lower your risk of more serious complications like heart attacks or strokes. There are many resources we can provide to help you quit, including nicotine replacement therapies, medications, and counseling support. You don't have to do it alone.
I guess it's time to really give it a shot. What about the pain in my legs? Will that go away if I quit smoking?
Quitting smoking and managing your other risk factors will definitely help reduce the severity of your symptoms, but it's also important to stay active. I know that sounds counterintuitive given the pain, but regular exercise like walking is actually one of the best treatments for PAD. Walking helps improve circulation by encouraging the growth of new blood vessels around the blocked arteries. We call it supervised exercise therapy, and it involves gradually increasing the amount of time you can walk without pain.
Exercise therapy. But walking is what triggers the pain in the first place.
That's true, and it's completely understandable that you'd want to avoid it. But what we do is create a plan where you walk until you feel the pain, then rest until it subsides, and then start walking again. Over time, you'll find that you can walk longer before the pain starts. It's important to push through the discomfort within safe limits, because it strengthens your muscles and improves blood flow to the legs. We'll guide you through the process and monitor your progress.
All right, I'm willing to try that. What if it doesn't work? Are there other options?
If lifestyle changes and exercise don't improve your symptoms enough, we can consider medications or more advanced treatments. Some medications can help improve blood flow and reduce the pain during walking. In more severe cases, there are procedures that can open up the blocked arteries, like angioplasty. This involves inserting a small balloon into the artery and inflating it to push the plaque aside. In some cases, a stent is also placed to keep the artery open. Another option is bypass surgery, where we create a new pathway around the blocked artery using a healthy blood vessel from another part of your body.
That sounds like a lot, but I'd rather try to avoid surgery if I can.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. You hear part of a surgical team's briefing. Now read the question.
Right, the next case is Mr. Davis, scheduled for lumbar spinal fusion. Are there any concerns from an anesthesia standpoint?
Overall, his general health is stable, though he has a history of sciatica. We'll monitor for nerve complications during surgery.
Do we anticipate needing any special neuromonitoring equipment?
Given his condition, we should have it available, but we don't expect major issues.
And how are we planning to manage post-operative pain?
He's been on oral analgesics for his back pain, but we might consider using a patient-controlled analgesia pump post-surgery for better pain management.
That makes sense, especially considering the extent of the surgery and the potential for nerve involvement.
Now look at question 26. You hear a nurse talking to her colleague about a patient's visitor restrictions. Now read the question.
They've come such a long way, and she's been asking about them non-stop.
I understand that, but her immune system is so weak right now. Any extra contact could pose a serious risk, especially given her recent setbacks.
They'll only be here for a short time, and I'll make sure they follow strict hygiene precautions.
Even with precautions, we need to prioritize her recovery. I don't want to compromise her health just to satisfy an emotional need, no matter how well-intentioned it is.
We could limit the visit to just a few minutes. That way, she gets to see them but stays protected.
I'd feel more comfortable if we wait until she's more stable. Right now, any exposure is a risk we can't afford to take.
Now look at question 27. You hear a physician talking to a patient. Now read the question. Mr. Sanders, you've been managing your heart failure quite well with the medications we've prescribed, but I understand you've been experiencing increased shortness of breath lately.
Yes, doctor. It's been harder to catch my breath, especially when I lie down. I've also noticed more swelling in my legs.
We've tried adjusting your diuretics, and you've had some oxygen therapy, but it sounds like we may need to discuss some additional options. I want to talk to you about your preferences if your symptoms continue to worsen.
I've spoken with my family about this. I don't want any invasive procedures like a pacemaker or a transplant if it comes to that.
Okay, I understand, and it's good that you've thought about these decisions. Now look at question 28. You hear part of an announcement in a ward. Now read the question.
Due to the increasing number of patients with multi-drug-resistant infections, such as MRSA, I would like to remind everyone about the essential protocols for managing these cases. First and foremost, isolation precautions must be followed at all times. Staff must ensure that patients with known or suspected drug-resistant infections are placed in single rooms or in designated areas. Proper use of personal protective equipment, such as gowns and gloves, is crucial to prevent cross-contamination. These items must be worn upon entering the room and removed before leaving, followed by immediate hand hygiene. This is particularly important as we have seen a rise in the number of these cases. Additionally, equipment used for these patients must be dedicated and not shared with other patients unless thoroughly disinfected. Finally, thorough environmental cleaning is mandatory in all rooms housing patients with drug-resistant infections. Let's all remain vigilant in adhering to these guidelines to control the spread.
Now look at question 29. You hear a presentation about new medication management education program for elderly patients. Now read the question.
Good afternoon, everyone. Today, Emma from the Geriatric Care Unit is here to talk about a new medication management education program for elderly patients.
Thank you for the introduction. What we are working on is developing an educational plan specifically designed for elderly patients who are managing multiple medications. These patients often face challenges like understanding correct dosages, coping with potential side effects, and maintaining adherence to their medication regimens. It's crucial that we consider their cognitive load, possible physical limitations, and the fact that they might be overwhelmed with the number of medications they are prescribed. I am here to get your feedback on 3 priority areas we've identified: risk of incorrect dosages, risk of adverse drug reactions, and
Now look at question 30. You hear a medical professional explaining a diagnostic procedure to a colleague. Now read the question.
For retinal diseases, particularly those that lead to progressive vision loss. Currently, treatment options for such conditions are limited, often requiring invasive surgeries or frequent injections into the eye. My goal has been to find a non-invasive way to administer therapies directly to the retina. I focused on using nanoparticles to transport regenerative compounds to the affected areas of the retina. These nanoparticles are engineered to carry and release compounds gradually, allowing for prolonged treatment effects. I've now developed a method that allows the compounds to be delivered continuously for up to 48 hours through eye drops. This not only reduces the need for frequent interventions, but also improves the chances of retinal repair. In the future, I aim to increase the duration of this treatment window and explore its applications for other retinal diseases.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For question 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Extract 1. Questions 31 to 36. You hear an interview with Dr. Talia Green about no-wait emergency room system. You now have 90 seconds to read questions.
Welcome, Dr. Talia Green. Today, we're discussing a new concept that's gaining traction in the healthcare industry, the no-wait emergency room system. To begin, could you tell us what this system is and why it's being considered as a possible solution to the problems that traditional emergency rooms face?
Thank you. The no-wait emergency room system is an ambitious idea aimed at reducing or eliminating waiting times for patients in emergency departments. As we know, long wait times are a persistent issue in many hospitals. The current triage system, while effective at prioritizing life-threatening cases, can result in significant delays for patients who are less critical but still need urgent care. The no-wait concept is about optimizing hospital resources, staff, and technology to provide immediate attention to all patients, regardless of the severity of their condition.
That sounds like a dramatic shift. What would such a system look like in practice?
In a no-wait ER, the goal would be to provide immediate medical evaluation as soon as a patient arrives, eliminating the traditional waiting process. This could be achieved by using real-time data analytics and predictive models to streamline patient flow and resource allocation. The idea is that by better managing available resources, whether it's staffing, treatment rooms, or medical equipment, every patient would be seen as soon as possible. In some experimental models, minor cases are handled through telemedicine or urgent care clinics, leaving the ER staff free to focus on more serious cases.
That sounds promising, but what are the downsides? Surely there are some challenges associated with this model?
Absolutely. One major challenge is the strain it could place on healthcare providers. Emergency rooms are already high-pressure environments, and expecting doctors and nurses to handle a constant flow of patients without downtime could lead to significant burnout. There's also the issue of resource management. Emergency departments may not have enough physical space, equipment, or staff to support the constant inflow of patients without expanding capacity. So, while it's appealing in theory, in practice, it could lead to overworked staff and strained resources.
That makes sense. Has any hospital attempted to implement a no-wait system? And if so, what were the results?
Yes, there are a few hospitals in the US that have experimented with no-wait emergency rooms, usually by redirecting non-urgent cases to other facilities like urgent care centers. In these cases, patients with minor issues are treated elsewhere, and the emergency room focuses solely on serious cases. Early results have been promising, showing shorter wait times and higher patient satisfaction. However, this system has yet to be tested on a larger scale or in hospitals with higher patient volumes.
Speaking of patient satisfaction, how does this system affect how patients feel about their care?
That's an important point. Patient satisfaction is increasingly becoming a priority for hospitals as healthcare is becoming more consumer-driven. If patients can receive immediate care upon arrival, it would likely boost their overall experience, and hospitals that adopt a no-wait system could see improvements in their satisfaction scores. This could potentially give them an edge in a competitive healthcare market, especially as patient experience becomes a bigger factor in hospital evaluations.
Finally, do you think this system will become the norm for hospitals in the future?
It's hard to say. While the concept has undeniable benefits, improving patient outcomes, satisfaction, and perhaps even reducing healthcare costs, the challenges of implementation are substantial. Hospitals would need to invest heavily in staffing, infrastructure, and technology to make a no-wait system viable. So, while it's possible we'll see more hospitals experimenting with this model, it may be some time before it's widely adopted. The future of emergency care will likely involve a hybrid system where traditional triage is optimized to minimize waiting times without overburdening staff.
Extract 2. Questions 37 to 42. You hear Dr. Laura Matthews giving a detailed presentation on conducting complex conversations with patients. Now, read the questions. You now have 90 seconds to read questions. Good afternoon, everyone. I'm Dr. Laura Matthews, and today I'll be talking about one of the most challenging aspects of clinical practice, conducting complex conversations with patients. Whether it's discussing treatment options, addressing a terminal diagnosis, or setting end-of-life goals, these discussions can be emotionally charged and difficult for both the patient and the clinician. In such situations, the way we communicate is critical, It's not just about delivering information, but about offering support, showing empathy, and helping patients make informed decisions in some of the most difficult moments of their lives. As clinicians, we face these conversations more often than we'd like to admit. Yet, many of us feel ill-prepared for them. Studies have shown that a large number of healthcare professionals report feeling anxious or uncomfortable when tasked with having emotive discussions with patients or their families. The main reason for this is that most medical training focuses heavily on clinical skills, with less emphasis on the communication skills needed for delicate conversations. This lack of preparation leaves many clinicians feeling unsure of how to navigate these discussions, which can lead to stress for both the clinician and the patient. So, what can we do to improve? One area that has been gaining attention is training specifically focused on communication skills for emotive topics. These training sessions teach clinicians how to handle difficult conversations in a way that fosters trust, reduces confusion, and leads to more patient-centered care. One key skill emphasized in these trainings is active listening. Many of us are so focused on explaining the treatment options or outcomes that we forget to truly listen to what the patient or their family is saying. By developing this skill, clinicians can better understand the patient's values, concerns, and preferences, which allows for more meaningful discussions and decisions. Another important aspect is recognizing the emotions behind the words. Patients dealing with a serious illness or end-of-life decision-making are often scared, frustrated, or overwhelmed. And this can affect how they express themselves. It's our job to not only hear their words, but to understand the emotions driving them. By doing so, we can provide more compassionate care. A technique that helps here is reflective listening, where the clinician mirrors back what the patient has said, ensuring that both parties are on the same page. This small but powerful tool can help build rapport and make the patient feel understood. We recently ran a study at our hospital where we introduced a series of communication workshops for clinicians. These workshops focused on improving communication around sensitive topics like end-of-life care, advanced directives, and breaking bad news. Clinicians were given the opportunity to role-play difficult conversations with standardized patients, which allowed them to practice navigating these emotional discussions in a controlled environment. What we found was that many clinicians gained confidence in their ability to have these conversations. Before the workshops, they reported feeling apprehensive and even avoiding these discussions whenever possible. After the workshops, more than 70% said they felt more equipped to handle these conversations and were less likely to delay them. One of the key outcomes of the workshops was that clinicians developed a greater sense of self-awareness. This is crucial, because how we come across in these conversations can dramatically impact the patient's experience. For example, when delivering difficult news, our tone, body language, and even facial expressions can either provide comfort or heighten the patient's distress. Many of the participants realized that they had been unintentionally coming off as distant or rushed in these situations. By becoming more aware of their own behaviors, they were able to adopt a more compassionate and patient-centered approach. What does this mean for patient care? The results were clear. Clinicians who were more confident in their communication skills provided better care. Patients reported feeling more understood, less anxious, and more in control of their care decisions. This kind of open, compassionate communication is essential to delivering patient-centered care, especially when discussing emotionally charged topics. It fosters trust, helps patients feel valued, and improves the overall quality of the healthcare experience. Moving forward, I believe it's critical that more healthcare systems invest in this type of communication training. Not only does it benefit the clinician, but it also has a profound and positive impact on patient outcomes. To summarize, effective communication during complex clinician-patient conversations is a skill that needs to be developed and refined. Through focused training and practice, clinicians can learn to navigate these conversations with greater confidence and compassion, ultimately leading to better patient-centered care. Thank you for your time today, and I hope that this session has highlighted the importance of communication skills in handling sensitive patient discussions. That is the end of Part C. You now have 2 minutes to check your answers.